Welcome to Louisville Lectures, making learning and teaching easy for residents and students on the go. Join our residents from the University of Louisville as they share the highest yield internal medicine topics in digestible chunks.
Hey everyone, my name is Christian Matar, one of the MedPeds residents, and I just want to give a little lecture about hyperkalemia. So a lot of times I like to think about what it's like as an intern on nights, and one of the things you can often be called about is a potassium level that's elevated. If you're like me as an intern, then anything that's red gets you excited, but I would say that whenever you get this call, we look at what you can do, the treatment options for hyperkalemia. So often we're going to get worried about a level that's around 6 or above. Definitely can be concerning and definitely in the high 5s. And so what do you do about that? First thing you have to do is to think about, hey, is this a real value or not? So some reasons that you can have a falsely elevated potassium, which you got to think about, would be, number one, if the sample is hemolyzed. It's inside the blood cells, so if the blood cells break open because the tube was shook on the way to the lab or because there was a really hard lab draw, that can be an issue. So you have to look at that, and the lab will usually tell you if it's hemolyzed or not. If you're giving potassium-containing fluids in one area and draw the lab right after that, that definitely could cause an abnormally elevated level. So you got to think about some of those things. The next thing I like to do whenever you're doing this is to make sure that you get a good set of vital signs in your patient. You go see your patient and take a look at their chart while you're there. If the patient is symptomatic, that's saying, my heart's fluttering, which you would worry about with potassium, that's a more urgent issue than if they're sleeping comfortably. So you'll see that and you look at the chart and see, hey, is the potassium been going up for the last 2 or 3 days? Or is it just normal, and it jumps up all by itself? So if it's been progressively going up, that would make you worry that this is a real value that you need to do something about now. And if it has just kind of jumped up all of a sudden, that might mean it's more like an abnormal value and it would be worth repeating. So you go see your patient, they're stable, not having any symptoms at the time. You call the nurse on your way, you say, hey, can you give me some vital signs? And they're normal. What's next do you want to do? So in addition to thinking about repeating the level, next thing you want to think about is, hey, let's see if there's any problems that the potassium is causing. As I mentioned before, fluttering heart would be a big one because we worry about EKG changes. So the next thing I would do is get an EKG. So what are you looking for on the EKG? You're looking for rhythm changes, hyperpolarization, where the potassium is affecting the rate of the heart. So here's a way I like to think about it, and I've taught this before, and I think it's a really neat memory hook, is look at your normal EKG. Then imagine that right distal to the T wave, you have a fisherman sitting there who throws a fishing hook and hooks onto the T wave and starts to pull. This is going to simulate what potassium does. So first, it's going to peak that T wave. It becomes very tall right there, and that's one of the first signs you'll see of hyperkalemia. As the fisherman continues to pull, he's going to spread out that EKG. So the next thing you see is that the QRS duration becomes prolonged. This is very concerning. As he continues to pull, everything gets stretched out and the P wave goes away. It flattens out. This is a very concerning EKG. And then after that is a sine wave, and after that is asystole, all badness. So these are the changes you're looking for, the first one being the peak T waves. So your EKG, whether it shows T wave changes or not, can help you decide what you're going to do for therapy. So what can we do for therapy? So the first thing we think about is the potassium is too high in the blood right now, and we need to fix that immediately, especially if it's causing T wave changes. So one of the first things we think about is stabilizing the cardiac membrane. And people often think about this, and that's with calcium. It's a cation, and what it can do with the calcium positive charge is stabilize the membrane so it doesn't have this hyperpolarization. If you see T wave changes, you need to give calcium now. Calcium gluconate is what we usually give. If you don't see the T wave changes, calcium gluconate only lasts for like 5 or 10 minutes, so it's really trying to buy you time. So sometimes you can give it, but really it's with the EKG changes you want to do this. So you have calcium gluconate. Just as a note, calcium gluconate has to be activated in the liver. So if you can't really go through the liver well, you can't give it. For instance, in a code scenario. In that scenario, you'd want to give calcium chloride. We don't often give this because it burns through a peripheral IV, and it's usually given through a central line. So you can give calcium gluconate. And the next thing I want to think about is how do I decrease the amount of potassium in the blood, but maybe not necessarily get rid of it completely. I just want to shift it around. So one of the first things you can do is a fluid bolus. Now, if you have a patient that has renal disease, and that's people that can have high potassium, you got to be careful with this, but you can give a fluid bolus to try to dilute out the potassium. And then we think of ways to shift it out of the blood and into the cells. So the medications that we majorly think about would be insulin. Insulin shifts potassium into the cells, but it also shifts glucose. So whenever you give insulin, we give insulin with dextrose. You give them together. Really give them as much dextrose as you can. You don't want their blood sugar to go low. You just want to shift that potassium and keep their blood sugar elevated. So you give insulin and dextrose. Another one that shifts into the cells would be albuterol or beta-2 agonists. So you can give an albuterol dose. We don't really give it IV, though it is available. You can have albuterol. And another one would be acidosis makes potassium come into the blood. So you do alkalosis by giving sodium bicarb. That's another one that you can do to shift potassium into the cells. So once you can stabilize the membrane, then we think about shifting with a bolus, insulin and dextrose, albuterol or sodium bicarb. And then we try to think about how can we get the potassium out of the body if it's truly an elevated number. So depending on the person's clinical scenarios, depending on what you're going to do, but your options really to get it out are you to urinate it out or to lose it in the stool. So in order to get it out in the urine, we have to give loop diuretics. Those are the ones that get rid of potassium. So that's going to be Bumex or Lasix. So you can give that, and that'll take, a couple hours, maybe 3 or 4 to actually work. So you have to buy your time to get there. Or you can get in the stool, what we often think of as K-exolate. This can cause some bowel necrosis if there's some constipation. So instead, I would think about giving something that just causes them to have stool. Lactulose, you can give K-exolate if you want to, but anything that causes you to stool should cause you to lose potassium. So those are some of the ways you can definitively get it out. Now, say that you've tried some of these things. There are EKG changes. The patient is on telemetry, which is a good thing to put these patients on if they do have elevated potassium. And there are changes, but it's not working. Then what is a definitive way to get potassium out now in a very quick way? And that's going to be dialysis. So with refractory hyperkalemia and you're not able to get it out through the urine because they don't make urine, you do dialysis. It's one of the reasons for urgent dialysis. Just while we're here briefly, I want to mention the AEIOUs of dialysis. It's the reason for doing dialysis. It's going to be acidosis. E would be electrolytes, mainly potassium. I is ingestions like aspirin or ethylene glycol, things like that. O is going to be volume overload. And then U is uremia. So this would be E, electrolytes, potassium. That'd be a reason for dialysis. So these are kind of the ways that you can go about treating hyperkalemia. Again, many of this is going to be patient specific. So if you have renal disease, they probably need dialysis. But if they're a well patient, you need to make sure, A, is this a real value? B, are we giving them potassium, like in their IV fluids or orally? We should stop doing that. And then C, how are we going to treat it? Do you need to shift it? Do you need to stabilize the membrane? Or do you need to get it out of the body? So some take-home points for hyperkalemia. Number 1, hyperkalemia above 6 or EKG changes is concerning and needs immediate intervention. Number 2, calcium gluconate can be used to stabilize the membrane, especially if EKG changes are noted. And number 3, with treatment, you can either shift potassium out of the blood, but as a temporizing measure, and after that, you need to remove it from the body for some definitive way.
Remember that these are only temporizing measures. You must have frequent and close follow-up with repeat potassium values to make sure that they are trending in the correct direction.
Thank you for watching Little Lectures. My name is Christian. Please stay tuned for other Little Lectures that you'll find on this website.
Thanks for listening and learning with us. If you would like more information on this topic, please take a look at our full-size Louisville Lectures, either on louisvillelectures.org, on our YouTube channel, or on our podcast.